Okay, now let's move on to postpartum complications and family at risk. Oh, baby. So hemorrhage is number one that we have been talking about. So description of hemorrhage. So for a vaginal delivery, a normal vaginal delivery, it's 500 cc's or more. For a C-section, 1,000 cc's or more. You'll see it written as an EBL, estimated blood loss, on the reports, okay, for delivery. So we also want to look at the H&H, the hematocrit. So decrease of 10 points or less. The need for fluid replacement after birth to bring up her blood pressure. So early postpartum hemorrhage is within that first 24 hours. That's when the patient is at highest risk for hemorrhage. And what that can be, caused by retained fragments of placenta. Okay, uterine atony is where the uterus is boggy. It's not hard and firm like we want it to be. So when we go to palpate and for the fundus, you'll see there's lots of blood and maybe retained fragments that are coming out. So remember, you want to look to see where is that? Is that a constant trickle, or is it just an occasional? If it's a constant trickle, there may be some lacerations or other injuries. Could be due to an episiotomy. They're pretty large. They're pretty standard, and or inversion of the uterus. I believe that they were pushing extremely hard on one mom's uterus last week, and that's not good. When they're forcefully pushing the infant out from the fundus, it can cause uterine inversion, which is very bad. We used to do that more frequent years ago, but they discovered that yes, you can push that uterus right out, and subsequently had lead to further complications. Hematomas like vulvar, vaginal, or even peritoneal hematomas, or any bleeding disorders can be due to early postpartum hemorrhage. So here you see, you have, oops, let me see, sorry. Oh, that's odd. A contracted uterus over here as it contracts down, and then you have over here, you can see what it shows is that uterine atony, um, and there are remains of placenta still inside there. So if there still remains, that uterus is not going to contract down like we want it to, and she'll continue to bleed. Other reasons could be there's more than one fetus. Maybe it's a quadruple or a sextuplet, or who knows. Anesthesia, which can also relax the uterus, any uterine infections, Pitocin. So each of these can be affected or can predispose the uterus to hemorrhage. So the most common causes are the placenta is still maybe remains attached. So there's different degrees of it. Placenta accreta, when parts of the placenta, when they're growing, they grow deeper into the endometrium and they grow into the myometrium. That's 80% of it. And it's called placenta accreta, which can lead to hemorrhage. The placenta does not separate from the uterine wall and it just continues to bleed, and it may have to be taken to the OR for removal of that. Or an increto, where it where the placenta grows into, could be organs or other placental places, percreta. A hysterectomy, yes, it might be necessary just to remove that, unfortunately. Um, but the most common We have retained placenta, which is the most common cause, and you'll see all those fragments coming out as like large clots or clotting. And the provider will take the patient to the OR for surgical removal and DNC, where they scrape out the contents of the uterus. So there's a couple of different ways that uterine postpartum hemorrhage with where a fundal massage can be done. We do it externally by placing the hand um, over the suprapubic bone and then massaging the fundus. Okay, that's what we do. You can see it. Uterine atony, the hemorrhage, the blood flow continues into the uterus. So we want to stop that flow if it's in the uterine, intrauterine. So this is one way that the provider can do it, which obviously, if his whole fist and hand is up in there, is pretty painful. It's a manual fundal massage. However, we do have other tools that we use that can be that can be utilized as well. So, um, so obviously this shows a DNC, dilation and curettage, where they try to remove the contents that are in there. Okay, so laceration of the birth canal, yes, if there continues to be blood flow and it doesn't stop, even if a small one, it could be a laceration. Could be cervical or it could be a vaginal laceration. So cervical laceration, it needs to be repaired or sutured, so the patient again will have to be taken to the OR, and you can see that early on. So we look for these things, signs and symptoms. We know what shock is. So this is loss of blood, body fluids, okay, bradycardia, tachycardia. You should have learned that in nursing 111. Okay, so the first thing you want to do if your patient is hemorrhaging is what? We need to take her vital signs to confirm that, what's going on with her. Confirms our diagnosis. So thing we do is we externally massage the uterus. Okay. The bimanual is a hand in and a hand out. That's something the provider would do. If it's a C-section, yes, you still need to massage that. You need it to contract down. So you still need to check that fundus. And has the patient received any Pitocin or oxytocin? Policy is that all patients receive that after delivery. Okay. If she's really lost a lot of blood, she may need transfusion, and hopefully we would have some packed red blood cells on hand for her. Um, Hemorrhage, obviously, this shows that you have to support the fundus when you go to massage it, and it's just showing you how that's done. And you did that in lab. So medications that could potentially be used, you want to look at the algorithm. The first recourse is Pitocin, and then Methergin, prostaglandins, which is creates contractions. Okay, each of these do. Um, as long as it's caused by uterine atony, yes, they can be effective. However, we may have to lead on to other things. So interventions, okay. So these are some of the things that you might see, especially like side attack. If you place 3 of those pills intravaginally for hemorrhage, you're going to have that diarrhea. So, in complications you may see from those medications. So, late postpartum hemorrhage is after the first 24 hours, and it can be within that 1 to 2 weeks. So, remember, I think it was Ashley was telling um, in lab that she had retained placental fragments, and they didn't actually um, come out until a week after she even went home. So that's why we have to educate our patients on signs and symptoms of hemorrhage and what that means. Okay, so remember, it's called subinvolution, where the uterus does not go back to its pre-pregnancy um, place, size, okay? And sometimes these are what you can see is greater. It's just not contracting down. And we don't see any of this. It continues to remain loci rubra instead of following the progression. Um, so look for those signs and symptoms. And this is a kind of a guesstimate of what you would expect, that maybe right after delivery you might have a heavy amount of flow, but that should lighten up as the day progresses or even as the weeks progress. But if the patient is soaking a peri-pad an hour, that's way too much, and they need to be seen by a provider ASAP, because they can go to those early signs and symptoms of shock. Okay, you notice these things when you do their vital signs, or maybe it's been a while already. And so when they start saying, I can't breathe, and it can lead to death, yes. So these are some of the treatments needed for postpartum hemorrhage, possible things that we could do. Of course, if there's retained placental fragments, they may be ruin in there, so we also would want to do antibiotics. Okay, so here's some nursing interventions. Okay, these are directed specifically. Know what her urine is she putting out. Um, Maybe she'll need a Foley to keep better track of that. What it was her CBC. If it's less than 21, what does the policy say? Is it to transfuse her? Obviously, long before that, we would have notified the provider, and of course, we want her to rest. Infection is our number 2. Okay, any infection occurs within 28 days of delivery or abortion. So you have what's called a puerperal infection. That's where you have initial infection and it spreads throughout the body. It can do that. Okay, and it can happen up to 6 weeks postpartum. That's why we tell mom, if you have a temp over 100.4, if you have pain, if you have pain that doesn't go away even after medications, if you have foul smelling lochia. So the infection can spread up into the pelvic lining, uterine lining, the peritoneal cavity, and the tubes, which can later affect fertility or infertility. So this just gives you a picture. So this is the reason you want your patient to be in more of a semi-Fowler's position. You don't want the blood to pool inside. You want it to come out. So because if it pools in there, it could also cook in there. Make sure she changes her pad frequently and she cleanses herself front to back, so it can travel throughout the body and affect all of these organs. Okay. So these are just some definitions of what you would be looking for and what are some of the signs and symptoms of some of these. As we said, what does the hospital policy say? You say it's usually over 100.4. We tell the patient to call her provider. Okay, any of these occurring 10 days postpartum. So there could be lots of reasons. We want to make sure she washes all of this bacteria. An infection is the bacteria. Make sure she washes her hands. She washes front to back, um, and has good habits. So yes, prevention of infection. Teach her how to use that peri-wash bottle. And eating right. Remember, we want her to eat foods that promote healing. So what kind of diet does she have? So then you have endometritis or metritis, and these are some of the causative agents of that. that may need to be treated. Okay, that's where you see specifically your elevated WBCs, anorexia, backache, okay, enlarged uterus. Again, your high Fowler's position. These are the nursing and the treatments for that. Cellulitis, again, that can lead to other organs. Peritonitis. These are when they're very, very sick because it affects the lymphatic system, which travels through the body. Salpingitis, these are the tubal infection. Yes, it can create or cause problems um, for infertility in future, trying to get pregnant in the future. And this is what this would look like. It just all the swelling and stuff here looks painful to me. Okay, so we're always going to be looking at the perineum. Where is the bleeding come from? If she has any stitches or sutures, are they still intact? And what do they look like? Is there any swelling? So another problem that can happen, especially for a woman with a history of clotting issues, is thrombophlebitis. Okay, um, if she doesn't get out of bed right away and walk around and get her circulation flowing after a surgery, any woman can have clotting issues. Okay, so we want to make sure she gets up and walk as soon as possible. And so that's kind of a reason to take out the Foley because she's got to get up and walk to the bathroom after having surgery. So it's inflammation, obviously, thrombolytis, and this is different from pleothrombosis, which is non-inflammatory. We'll look at you want to look at what happens here. Increased risk because DIC is disseminated intravascular coagulation. There's problems with clotting. There's clotting issues here, basically, is what you want to know. Okay, so these risks, especially they increase with increased maternal age and all these other that are listed here. So there's different superficial thrombophlebitis where you just see it on the surface, or femoral or pelvic. Those are pretty self-explanatory, I think. I'm not going to go into great detail of these. You should have read up more about what they are in your med-surg part, but the signs and symptoms and when they usually present is what you really want to know. So superficial is 3 to 4 days, and you can see the redness and there's swelling here, swelling noted. And how do we treat that? Usually it's just elevation, bed rest, and local heat. Maybe TED stockings on. Okay, so here, femoral and pelvic thrombophlebitis. So complications can be like pregnancy-induced hypertension and C-sections. Those are things that put these women at risk for these complications. So signs and symptoms, you can see the difference in each of these. Very specific. Here's deep vein thrombosis. See the extreme swelling here. And what do we do for them? Obviously, we're never going to massage it because you might dislodge any clots and it could go directly to the heart or other organ. Okay, treatments for this, as I said, know what specifically the treatments are. Okay, this just shows the affected veins. And this is just when they come back from the OR, or no, thrombolysis, but when they do come back from the OR, they had the compression stocking them. I think this looks like it might be a heat applied to the area. And pelvic is second postpartum week. What they're caused by. How do we treat it? Coumadin is something that we don't commonly see, but yes, it has been used. I won't say it hasn't at all because it has. But with Coumadin, because it's a blend fitter, no breastfeeding. Okay, pregnancy risk category. This talks about pulmonary embolism. Okay, there's a clot that's dislodged into the lungs. Signs and symptoms that you see. Often you see the patient first begin with shortness of the breath, or yeah, shortness of the chest, and shortness of breath and chest pain. And what do you do for that? Obviously, we always monitor our vital signs, okay? And what kind of treatments? Already said some involution is caused by infection. It can be or retained placental fragments. I think this is just a rerun of the previous here. What do we do for that? And then we have mastitis. Inflammation of the breasts, usually in breastfeeding mothers, and it can happen after delivery. So the big thing is, yeah, it can be past infection or bacteria, sorry, from the baby's nose and throat to the mother's breaths, things like thrush, etc. Or if baby's not latching on and she has cracked and bleeding nipples. So we want to make sure, obviously, that mom she can wash her breasts as well as wash her hands when she goes to breastfeed. And mastitis is one of the worst things that you can have. I thought I was dying when I had it. You just have no energy and very high temperatures. The thing you want to do is pump more frequently. So the milk ducts, they run all the way up into the armpit. Okay, so these are some of the things that you might see. The lymph nodes are enlarged if you have the mastitis. And here, this was just shows a reddened spot or just a tender spot, or it might not even be tender. It might be just reddened. So this is early. It might start out small and affects the lymph nodes. You can see some swelling, and then it gets bigger as it gets more extreme. Okay, UTIs, we know about UTIs. So mom, afterwards is her bladder is more susceptible. Um, if she's not washing front to back, if she's not cleaning herself well, she's not changing her pad as often, and she's not even voiding on a regular basis. So she's at higher risk for urinary tract infections. Some of the things you see is, of course, that increased white blood cells, bacteria, hematuria, proteinuria, and it can affect, if it's been present for a while, it can actually affect the kidneys after a while. So nursing, what do we do for that? Here you go. So it's common, yes, to have UTIs in postpartum patients. Cystitis, okay, is another thing that you might see. Again, you can see how that's treated. Vulvar hematoma, well, your patient may have had a normal sterile vaginal delivery, but she can develop a hematoma later after the delivery. So that's why you want to make sure that you look at the perineal area. If she's had any kind of trauma to the perineum, that can develop. Okay, So things that you might see are like her inability to void. You can feel a hardener, you can see a raised elevated area, and you can have it on the vulva, on the vulva, which is very painful. Okay, here it shows this down here. Okay, this one's a vaginal one, and this is a vulvar one here. Oh, okay. So write down your questions to ask me later when you see me or when we meet up or when we do a Zoom. Please write down your questions that you have. Thank you.